So once again, it's my great pleasure to introduce Editor Emeritus of GEMS, Mr. A J Heightman.
Hey, I'm back. Everything I do, I appreciate the award, everything I do is for you and for your patients. Now, I want to talk to you from my heart today because I'm mostly an educator. Instructors have a limited amount of time to impart their curriculum and their knowledge on you, and I'm not picking on instructors this morning. I'm picking on the fact that we have to use educational sessions and street experience to fill in the gaps in our knowledge. So I want to address some of the gaps I've encountered in my knowledge base in my career, and particularly in my life the last 2 years. Each year I help host 24 Australian paramedic students who travel to the United States to visit very busy EMS systems, to do hours of ride-alongs and exchange ideas on patient care. They spend at least 3 years in school in Australia, and they do a deep dive on a lot of things that we don't, like research and assessment care. I like to meet with them on the tail end of their 2-week tour to pick their brains and to get their impressions on what they saw and what they learned. Now, the past 2 years, they told me that many of our paramedics know what they know, but don't know what they don't know. That was concerning to me. They gave me a few examples, noting that crews failed to bring suction in with them on priority calls, that few carried or used thermometers, and how did they even tell whether a person was septic? And many lacked splints to immobilize pelvic fractures. More concerning was the fact that many paramedics said they weren't interested in learning anything outside their protocols or their practice. That caused me to recall a Con Ed, a lecture on trauma when I was a very young paramedic by a very good trauma surgeon who lectured on coup contra coup injuries. I'd never heard of coup contra coup injuries. It wasn't in our curriculum. And he talked about the brain bouncing around inside the head and the devastating effects of that. He also referred to violent heaving that's commonly seen in severe brain injured patients. And he kind of mimicked that heaving. It was really not productive. More on that later. It's an added extra. I handled a pedestrian accident a few months later, and as I assessed the patient, I felt like that surgeon was whispering in my ear, "It's a coup contra coup injury. It's a coup contra coup injury." So I made the decision. I passed several hospitals to go to the closest trauma center, called in a trauma alert, and later learned the patient did in fact have a bleed that could have killed him if not managed rapidly. That was a knowledge gap that had been closed. Let's talk for a minute about one so-called benign condition I experienced, a kidney stone. Anybody ever had one? I was taught that kidney stones, in my textbook, said it was a non-traumatic emergency due to inflammation, infection, or obstruction that presents with excruciating flank pain. Oh, that should have been capitalized. But I learned it was not a benign condition 15 years later when I awoke in the middle of the night to a sesame seed-sized stone that felt like a 20-pound piece of kryptonite or glass that was wedged in my urinary system. The pain and bladder pressure was indescribable. About 15% of you are going to suffer from kidney stones at some point in your life. And if you develop them, about 70% of you will have a reoccurrence. Isn't that nice? So you better have some sympathy for people like me who've suffered from them multiple times. Now, our protocols back then wouldn't allow us to give 10 milligrams of morphine, so the crew was limited to titrating the morphine and giving more than 3 milligrams at a time. See, they were afraid that if we gave 10 milligrams to anybody, we would go into respiratory arrest. Are you freaking kidding me? When I went to the ED for my kidney stone, luckily, a nurse paramedic colleague who I know pushed in, wham, 10 milligrams of MS, and I immediately felt that warm sensation. The pain went away, and I became eternally grateful to her. And I realized the next time I had a kidney stone patient, wham. The lesson learned, give enough juice to satisfy the pain goose. Got it? Here's another benign condition I experienced. I was taught that AFib was also a rather benign condition. An irregular rhythm with multiple ectopics throughout the atria. Even though my instructor stressed that with the atria and ventricles not contracting in sequence, we could have a cardiac output failure of at least 25%. They told us it was not really a true emergency unless the patient in the field heart rate increased significantly, at which point cardioversion might be required. If you've ever cardioverted somebody, you know what I'm talking about. AFib was therefore our easiest test question in the cardiology section, but one of my worst life lessons. It impacted me in 2017 while I was in New Zealand, of all places, lecturing at an EMS conference. While walking to and from the conference center, I was ashamed to tell my New Zealand and Australian colleagues that I couldn't keep up with them, that I was short of breath, and I was having palpitations. I was in AFib and I didn't realize it. I flew home. The day later, when I got back to the US, I went to a cardiologist who found I was in AFib and thought, in fact, maybe you had a PE. Brilliant. But I was sent home without any meds and told to return in a week to be watched. Ironically, 2 days later, after stuffing my face on Thanksgiving, I awoke with chest pain, shortness of breath, was admitted to the hospital, and experienced all the excitement of the cath lab. I always wanted to be in the cath lab, but not as the patient. I was found to have clear arteries, no problem. But they said it was GERD, G-E-R-D. Nobody taught me about GERD. I'd never heard of gastroesophageal reflux disease. The cure? Sleep with your head up and eat right. Holy crap, I went through all that stuff. I spent the next 12 months, though, moving through the treacherous AFib highway with periodic heart palpitations, shortness of breath, and some chest pain. Treatment included meds for BP, rate and rhythm control, and the blood thinner Eliquis. Oh, more on that later. To prevent clots from developing, which could cause a stroke. I quickly learned that you can go in and out of AFib regularly, and was soon an expert at saying to my wife or my family, I'm in AFib, because I had now connected the dots. They soon decided to have me come in for cardioversion. Oh, I got myself mentally prepared. I had done it in the field, but was not told not to worry because they would give me propofol to knock me out before the shock. Oh, Michael Jackson, thank you. I got fully prepped for the cardioversion, 5 o'clock in the morning. But right before the procedure, the nurse came in and said, you can go home. You flip back into normal sinus. Oh, shit, no propofol. I said, can I take the propofol home? She said, no, sorry. 6 months later, though, and 8 trips to the cardiologist later, the decision was made to have me undergo cardiac ablation. They never taught me about that in school because my AFib was returning too frequently. I never asked a patient if they had multiple periods of AFib. That was never something I thought I had to explain to the emergency department. Now I know. Because if it's returning too frequently, you're putting yourself at risk for a stroke, or worse, cardiac arrest. The cardiac interventionalist went in, great guy, zapped the problem areas, destroying them to disrupt the faulty electrical signals. I woke up in my bed, I felt great. But then I was told that AFib can still occur while the scarring isn't completely healed. And it did. So after a few occurrences and a little implanted thing that would tell them when I was in AFib, they called and said, come on in. We're going to cardiovert you, get you back in rhythm. Oh, joy. I went in for 2 cardioversions over the next 3 weeks. quick, easy fixes for post-ablation AFib, and had a great propofol experience each time. I highly recommend it. I've now been free of AFib for 2.5 years, and I became a zealot on educating people like yourself and others about the dangers of AFib. But sadly, on September 11th of last year, I sat across the table from my wonderful colleague, Brian Fast, our beloved EMS fitness guru, at an EMS conference in Greensboro, North Carolina. But I was unaware that he was battling AFib at the time and contemplating having ablation performed. No, let me underline that. His physician was kind of delaying the ablation being performed. Sadly, he died 2 days later, collapsing at home, way before his time. God bless you, Brian. Because people are living longer, heredity is a part of it and can pass along AFib, as can increased stress in our lives. Did you know that? No, you don't have any stress. It's expected that the number of people experiencing AFib will quadruple in the next 10 years. If you connect the dots, you quickly understand AFib's relationship to heart-related complications like blood clots, stroke, heart failure. Teach others that AFib is a gap in our knowledge base. Teach crews not to miss or dismiss it during assessments, and don't take it lightly when you, your patients, or your loved ones have it. Now on to my last amazing knowledge gap and medical adventure. Oh my God. It was May 16th. I'd been on the road for a week. I'd had several different assignments, lectures, interviews, felt great. Was coming home, going to see my granddaughters, going to see my family, got home late at night. I was a little tired, of course, and still had a nagging stiff neck that had bothered me for weeks. I had gone to my chiropractor a couple times for neck adjustments to relax my tight muscles before I traveled. And one day, the main guy that I trusted the most wasn't there, and somebody else cracked my neck. And he was a little rough. And I told him that. As I sat and watched TV that night, after my son and his wife went up to bed, it's about midnight, I suddenly felt the worst headache I'd ever experienced. I told my wife, I feel like somebody just shot me in the head. She said, what are you talking about? Maybe I had 2 drinks, that was too much. I said, hell no, 2 drinks aren't enough. I said, why don't you go upstairs? I felt like I was going to collapse. I began to start feeling strange, began to get very, very wet and diaphoretic. I tried to get out of my chair, but had no feeling or control on my left side. I fell to the floor like a porpoise. I tried to get up again, but just flopped further to my left on the floor. The rest of the evening was an out-of-body experience for me. She woke my son, who had EMT experience. He did a stroke assessment. They called 911. I laid there looking, saying, this can't be happening to me. Is this it? Am I having a stroke? No. The fire department sent an ALS ambulance to my house. And then, as bad as I felt laying there, remember last year I talked to you about my dad hating people coming into the house in turnout gear? Ba-dum, ba-dum, ba-dum. 6 firefighter paramedics in turnout gear. For me, a stroke victim. They should have laid a line, brought a line in and hosed me down. That's a teaching moment. Again, it's hard to move around in turnout gear, and I don't need your carcinogens in my house. Several other teaching moments began with a young paramedic saying, sir, could you get up and get on our stretcher? I'm like, you got to be kidding me. I'm thinking to myself, do you know who you're talking to? If I could get on your stretcher, I'd have done it out at the curb. Much of their assessment and care was a blur to me, but I remember looking around for a suction unit and oxygen as I started to violently heave. Remember that? There was no oxygen. There was no suction unit. They weren't starting a line on me, but they hurried me to the unit. I had a flashback, a big flashback to that trauma surgeon noting that violent heaving was classic with severe head injury. Oh, shit. I knew immediately I was in trouble with a serious brain injury that was causing the heaving. The best teaching moment, though, occurred when I realized that they were running me code 3 to the hospital. Fire them up, boys. They called in a stroke alert. There's only one medic in the back of the unit, though. I looked around. They had peeled off the 4 other firefighter paramedics and sent them back to quarters. Hope they had a good night rest, because I didn't. The solo medic was busy in the back tapping into his laptop and radioing in his report. So he handed me a little bag to heave in, which was non-productive. There was no airway medic. There was no suction for me. There was no oxygen put on my face. All the basics of basic life support were not there. Oh, but I got an IV. You know how I remember it? Because the backup alarm was going on the ambulance as they backed up to the ED. You got to be kidding me, right? I'm thinking to myself, if I was in trouble, I could die with one young, great paramedic and 4 other guys that weren't there. They should have peeled somebody off. The message, if you go code 3, bring 1 more crew member for me. Got it? It was frightening to hear them say he's had a stroke. Holy crap, as they rushed me to the CAT scanner. It's even more frightening as I laid in the CAT scanner and I thought, oh crap, if they find a clot, they won't be able to inject a clot buster because I'm on Eliquis, a blood thinner. If they inject it, I'm going to bleed in my brain. Fortunately, I had suffered a ventricular arterial occlusion, a VAO, which you've never heard of, because they didn't teach you about that. Not caused by a clot, that temporarily shut down the blood supply to the left side of my brain, possibly caused by swelling from excessive chiropractic manipulation. It was a sudden clamp. It was a temporary placed on my vertebral artery. I didn't even know where the vertebral artery was. After 2 days in the neuro unit, my vision started to come back. I began to self-heal. I began to regain all motor and visual functions. And they said, if you can climb 3 flights of stairs, you can go home today to see your grandkids. Shit, give me those stairs. I was out of there, man. I was one of the lucky 13% of patients suffering puzzling occlusions and dissections with no permanent brain damage. You're going to hear about a prominent other person in our EMS community that had a flap inside her vertebral artery twice. So she and I conspired to write an article that you'll hear pretty soon that'll give you a lot more information. I'd never heard about it. Never heard about a vertebral artery, let alone occlusions or dissections. And they're hereditary too. But they can occur frequently. Now, my goal was to connect a few dots for you this morning, to fill some knowledge gaps for you, with the hope that you'll work to pass this information along to others to help save patients' lives, perhaps your own, and I hope I did so. I'm A J Heightman, and I approve this message. Thank you.